Anterior Cruciate Ligament Sprain by Austin Price. What is a sprain? A sprain refers to the overstretching or tearing of ligaments. In the knee, there are four major ligaments that could be sprained due to overstretching. Common signs are swelling, pain, bruising, lack of movement, and a sense of weakness in the knee. Types of knee sprains. There are three types of knee sprains. Grade 1 sprains. The ligament is mildly damaged in a grade 1 sprain. It has been slightly stretched, but is still able to hold and keep the knee joint stable. Grade 2 sprains. A grade 2 sprain stretches the ligament to the point where it becomes loose. This is often referred to as a partial tear of the ligament. Grade 3 sprain. This type of sprain is most commonly referred to as a complete tear of the ligament. The ligament has been split into two pieces and the knee joint is unstable. Each of these have different types of soft tissue healing. Stage 1. Acute stage, which is the inflammatory phase. This happens on the first 3 to 7 days post-injury. Inflammation is the body's attempt to protect itself. It is caused by any stimulus the body deems to be harmful or potentially harmful. In some cases, the inflammatory response can be over-exaggerated and can be harmful, i.e., anaphylactic shock. However, in most cases, inflammation is therapeutic because the ultimate aim is to protect the threatened tissues from further harm or injury whilst going through the repair process. This section focuses on the inflammatory response initiated by damaged tissues. Small microtears caused by dysfunction may also cause some inflammation. The process will be the same, although the individual may not be aware of any signs or symptoms. Stage 2. Subacute stage, which is the repair stage. This happens 3 to 7 days to 3 to 6 weeks post-injury. New blood vessels used to be formed at the injury site in order to supply oxygen and nutrients to the cells of the damaged tissues, with lymphatic vessels providing drainage. Fibroblasts migrate into the sticky matrix and begin to lay down in accordance with the multi-directional tensile stresses the tissues are subject to. If there are any insufficient tensile stresses applied to the tissue, collagen will form in a haphazard manner, resulting in an excess of unfavorable scar tissue or adhesions. This may limit the functionality of the repaired tissue and continue to dysfunction the injury cycle. The collagen will begin to contract, drawing the wound together and providing a permanent solution to the damaged tissue. Stage 3. Chronic stage, which is the remodeling phase. This happens 3 to 6 weeks to up to 2 years post-injury. The majority of the collagen fibers are laid down to the subacute stage of the healing process. Approximately 20% of tissue's original strength is regained by the start of the chronic stage. In the chronic stage, the body continues to lay down collagen fibers which act as a reinforcement to already formed scar tissue. The fibers continue to contract and align themselves with the tensile stresses, and remodeling occurs to cope with any increased stresses placed upon the area as normal function returns. The strength of the permanent scar tissue can be improved by suitable treatment, but even with the appropriate balance of stress and support, scar tissue will only ever reach a maximum of 80% of its pre-injury strength. This is because scar tissue has a higher proportion of strong collagen fibers compared with non-injured tissue, so it will lack some of its previous elasticity. Things that can affect knee sprains. Some people have a condition called hypermobility, which means the joints can be stretched over what is considered normal. In many ways, this can benefit an athlete as it could help prevent injury, but could also make a joint unstable, causing more significant damage to be done. A study done by M.J. Hall has suggested that patients with hypermobility syndrome have an effect on proprioception. Although this study does suggest that there is a clear problem with proprioception, the study was conducted on women who have a higher risk of injury than men. So this study is straight away biased in the sense that women suffer knee injuries more commonly than men, so it would be slightly unfair to suggest that hypermobility has a big impact on proprioception. Reasons why women are more prone to injury than men. The reason that women are more prone to knee injuries is because of the intercondylar notch. This is a groove at the bottom of the femur where it meets the knee. which is larger in men than in women. It is possible that the narrow notch in women restricts the movement of the ACL, especially during twisting movements. Also, women have wider hips than men, which can affect the alignment of the knee and leave women more prone to knees that move medial. This movement puts stress on the ACL, especially during the added force of landing a jump or turning. A study by Mary Lloyd Ireland has shown reasons for women having a higher injury rate. This study is very good as it really breaks down every reason why women sustain more ACL injuries than men. It also only looked at one sport, that being football, which again could only show injuries in that sport. Also, in football, ACL injuries are common in both men and women. So, as future reference would be to look at a sport that doesn't have ACL injuries so high up on the list, but also has similar movements. Causes of ACL injuries in sport. Here are a few movements. Changing direction rapidly, stopping suddenly, slowing down while running, landing from a jump incorrectly, direct contact or collision such as a football tackle. Risk factors for the ACL injuries include environmental factors, i.e. high level of friction between shoes and the playing surface, and anatomical factors like a narrow femoral intercondylar notch. The injury is characterized by joint instability, which is associated with both acute dysfunction and long-term degenerative changes, such as osteoarthritis and meniscal damage. Knee instability leads to a decreased activity, which can lead to poor knee-related quality of life. The risk factors for ACL injuries have been considered as either internal or external to an individual. External risk factors include type of competition, footwear, surface, and environmental conditions. Internal risk factors include anatomical, hormonal, or neuromuscular risk factors. Anatomy of the knee. In the knee, we have four major ligaments. The medial collateral ligament, which gives stability to the medial part of the knee. The lateral collateral ligament, which stabilizes the lateral part of the knee. Anterior cruciate ligament, which is located in the center of the knee and prevents excessive forward movement of the tibia. Posterior cruciate ligament, which is located in the center of the knee and prevents excessive backward shifting of the knee. The ACL originates from the medial aspect of the lateral femoral condyle in the intercondylar notch and inserts anterior to the intercondyloid eminence of the tibia, bending with the anterior horn of the medial meniscus. The ACL courses anteriorly, medially, and distally across the joint as it passes from the femur to the tibia. It gets its blood supply from the geniculate artery. The nerve innervation is the branches of the tibial nerve. The function of the innervation is proprioception and modulation of the quadriceps function. Biomechanics. The ACL is relatively prone to acute and chronic injuries as compared to other ligaments. Repair and self-healing of the ACL is a long process. For resuming an active sports life, a surgical repair or replacement is essential. Untreated ACL tears can result in osteoarthritis. Therefore, understanding the biomechanics of the injury and the properties of the ligament is crucial. The fibre bundles of the ACL do not function as simple bands of fibres with a constant tension. The fibres show a different tensioning pattern throughout full range of motion. The ACL splits into two functional bundles, the anteromedial bundle and the posterolateral bundle. In other words, some portions of the ligament is under tension always. The terminology of the bundles was chosen accordingly to their tibial insertion, with the fibres of the anteromedial bundle originating in the most proximal part of the femoral origin and inserting at the anteromedial tibial insertion. Diagnosis for ACL injury. Lockman's test. Test for the ACL is done with your knee bent approximately 20 to 30 degrees from horizontal. The leg should be externally rotated slightly. Place one hand behind the tibia and the other hand on the thigh. It is important that the thumb should be on the tibial tuberosity. On pulling the tibia anteriorly, an intact ACL should prevent forward translation movement of the tibia on the femur. A draw test. This is done with the knee bent at 90 degrees. Hold the proximal lower leg, just below the tibial-femoral joint line, and attempt to translate the lower leg anteriorly. The test is considered positive if there is a lack of end feel or excessive anterior translation relative to the contralateral side. This involves applying a sideways pressure on the joint while rotating and bending it. However, it can be difficult to perform in an acute situation or if the patient is very tense. It is more likely to be tried when examining a more chronic injury. The movement is a combination of axial load and valgus force during the knee flexion from an extended position. When the test is positive, it indicates an injury of the ACL. Treatment. There are so many types of treatment for an ACL injury. This depends on the scale of the injury. For a sprain, there are two very common types of treatment. These are ultrasound and laser therapy. As the ACL sits deep in the knee, ultrasound wouldn't be as effective for this kind of injury as it focuses on just beneath the skin injuries. A study conducted by Fung tested laser on the medial ligament on rats. One group with an injured ligament such as a sprain and the other with a rupture. Over the course of 3 to 6 weeks, both groups saw improvements. The group with the sprain showed greater signs of improvement. Although this study shows good sign of progression, it was conducted on rats and not humans. Humans have a lot more skin than rats, meaning on an area so small, improvement should be good. As the settings are adjustable though, this shouldn't matter too much. Laser has a large power range that offers versatile treatment options. A laser that can be set to operate from 0.5 watts all the way up to 25 watts, which allows a clinical flexibility to treat low and slow or at maximum output. When treating acute conditions with laser therapy, it is particularly effective when it is used as soon as possible following injury. The faster the inflammation is reduced and the healing process can begin, the better. In the case of acute injury, laser therapy helps restore the body to normal function quicker. With chronic conditions, laser therapy is used most often to help combat persistent pain and inflammation. Laser is being used at max power to help quickly reduce inflammation in patients suffering from chronic pain. Dosage is often prescribed after looking at the injury, but for the sake of a sprain, it will be on a low scale of watts, as it should be an acute injury. Also, massage would be a great factor to help recovery. As ligaments have such poor blood supply, a massage treatment would help get the blood moving around the injured area, in which delivering nutrients to the damaged area. This is a massive part of the body's self-healing process and will really help shorten the recovery time. Rehabilitation. There are a few exercises that should be done in the early stages of injury. These are isometric contractions of the quads. Seated on the floor with the leg extended and the other leg bent. Slowly contract the quadriceps of the injured knee without moving the leg and hold for 10 seconds. Passive extension of the knee. This allows the muscles to stay conditioned throughout the injury. This is done through the contraction of the quad. It will also help reduce any swelling that is surrounding the area. Standing knee flex. This helps keep the hamstrings activated. Calf raises. These can be done when full weight bearing can be achieved. Again, this helps keep muscles conditioned and active. Squats. These can be done once there is no pain throughout the movement. Lunge. This again should only be done once there is no pain throughout the movement. The lunge and the squat are great for knee injuries because they work the quadriceps and hamstrings. These exercises can be done at home with just body weight resistance. Advanced rehab. Ensuring that training is pain-free is the first step to take. Starting with bilateral training. This is using two limbs to create a movement, i.e. a squat or a deadlift. These types of exercises will be done in early stages of rehab and will progress the whole way through the rehabilitation process. Moving into more advanced training will also be necessary. Moving into unilateral training will also be a progression. This involves using just one limb to create a movement, i.e. a one-legged squat. Exercises that are essential are things like landing mechanics. This is a great place to start as it involves a neuromuscular involvement which could be a big problem after an ACL injury. Exercises can include a squat jump with a sticking of the landing and a hold for 3 seconds, and a one-legged drop that also involves sticking the landing. This then leads into proprioception training. This is all about controlling a specific movement. For example, a great method of regaining proprioception would be to balance on one leg and have the cones that the athlete has to touch with the base of their foot, while balancing on one leg. This movement should be slow and controlled. Progression would be moving the cones further away or using a balance board on the standing leg. Thanks for listening, and I hope you enjoy.